Executive's report. We move on now to item 4, NHS operational planning. Matthew, the Chief Executive, has already rolled the pitch. I invite you now to address the paper.
Thank you very much, Chairman. And yes, Simon has stolen part of my thunder, so thank you for that, Chief Executive. So, as Simon said, the operational planning guidance is now out on the went out on the 22nd of September. So I think generally a positive reception from the service, and thanks to NHSI, who we developed the work with jointly, and to our other partners who input into that piece of work. I think the theme that we were looking to get into the planning guidance was to create stability and certainty going forwards, and to create an environment where health systems could plan together, building on the work they've been doing on the STPs, and to avoid the risk that these became two separate exercises, the contracting process and the STP process. To this end, we brought the process forward by 3 months in order that we can get it done by the end of this year, and going into next year the NHS can focus on the doing rather than on the planning. We've published for consultation the 2-year tariff and the standard contract. We've published 2-year sequins and CCG quality premiums so that there is clarity around that, and we've kept the 9 must-dos, the quality metrics, the same. So we haven't dropped a whole lot of new targets into the system. And to reduce the bureaucracy and the overhead, we brought NHSEngland and NHSI together into a single oversight process. Bringing forward the contracting timetable to the end of this year has allowed us to align it with the STPs, which was, I think, crucial, because most importantly, what we've been trying to do is to create an environment whereby the joint planning that's gone on in every health system over the 4 to 5 year future is now reflected in the actual plans that are written for the next 2 years. And in order to enable that, we've created control totals for health systems so that organisations can work together to say how is the money best deployed across their health system in order to optimise the health output. So it's been a big piece of work, and thanks to all the people who've worked on it. The NHS is now deeply engaged in taking this forward, and I think it sets a new direction for joint planning, long-term strategy going forward, which as an approach to delivery, which I think is overall very positive.
Thank you, Matthew. I invite the board to offer observations or queries. So, Matthew, what could possibly go wrong?
Well, obviously, Malcolm, nothing can possibly go wrong.
No,
there is a significant. This is a big piece of work. The NHS is going through a large set of changes. The 5-year forward view has set an extremely ambitious agenda for the NHS. It's going to require us to rethink the model of care to deliver services focused on keeping people well, focused on health improvement, focused on keeping people out of hospital, and that's going to require us to move away from just doing more of the same into actually what should health look like for a particular population. So, we've asked a hard question of the NHS. Whilst it's under pressure from growing demand, and whilst finances and capital are constrained, but all of the signs coming out of the STP work is that people are heads down, really wanting to deliver, and I think that's positive. But this isn't a form-filling exercise. This is a real piece of management and planning.
Thank you, Simon, and then Victor.
So just supplementing that, I mean, in terms of things that are risk points, the exit position for 16-17, the financial exit position for 16-17, both for CCGs and for trusts, is obviously a substantial thing we've got to get right. Paul will talk more about that in his report. If we don't effectively deliver the end-year financial position through trusts and CCGs that we need to, then 17-18 is going to be very, very difficult. Secondly, NHS Improvement and NHSEngland will shortly be issuing proposed 17-18, 18-19 control totals for individual organisations. So not too much process of kind of, faffing around on that rather than actually getting those kind of understood, accepted, and then people working collectively to set themselves right for next year. I think that could otherwise be a big, they come at an opportunity cost to management focus. Thirdly, we signal quite explicitly that people are free to move away from activity-based payments in their local health economy where the relevant organisations can agree. That's not to say they have to, but if they want to, they shouldn't regard that as an obstacle or think of us standing in their way. The reality is that that requires a new set of ways of constructing sort of relationships and dialogue about what the future should look like. Given how tight funding is going to be next year and the year after, people aren't going to be able to just kind of trade their way out of problems with ramped volumes. Equally, CCGs aren't just going to be able to kind of pretend there aren't demand pressures when there are. So we're just trying to get people to focus on the honest constraints and conversations that are required rather than sort of retreating to their corners and trying to slug it out.
Victor?
I was just wondering about where, looking across the 44 STPs, where the biggest risks lie. I mean, obviously, Simon's already explained that they're in different stages of development, which is to be understood. Mm-hmm. But looking across the piece, and given the time constraints that have been placed on the planning, the STP process, where do you land the biggest risks? Is it the public patient engagement piece? Is it the reality of financial planning? What is it?
I think that I'd say that there's two things that the STPs really need to get right. One of them is very much reflecting what Simon has said, that this is a planning in partnership exercise, so people are not going back into their silos, but actually working together to say across health and social care, across primary and secondary care, how do we use the money most effectively, rather than going back into how do I protect my organisation. We've seen that coming together in the STPs, and I think the biggest risk is that people retreat back into a traditional contracting process. I think that's one big risk. I think the other area that STPs absolutely have to get right is the community engagement, the patient engagement, the public engagement in the set of changes that will emerge from this, that we're going to need to discuss and engage with the people who are using the services, because we are expecting STPs to be able to present options for how services will get better as well as how they'll get more efficient, and getting that story across and building a public understanding and confidence in this, I think is going to require an openness and a dialogue that we need to make sure we get right.
Thank you very much. I think the board has seen over the last few years steady improvement in the production of the planning guidance. I still recall a sort of Christmas Eve of a rush through document that nobody had ever properly read, and then a panic through to March, and then no finalisation even by then. So to be able to get the guidance out now, the threat of arbitration, oversight by two distinguished chief executives, and actually the expedition of getting to agreement, and as Simon put it, getting away from the deflection of senior management time and the opportunity costs, and getting on with the business, I think is a major step forward. So I'm sure the board welcomes the new guidance, and we look forward to following its progress through. Control totals will be another part of the structure, but I don't think that we could at this stage anticipate any better approach to what we're trying to do with the STP.